Nance to introduce our grand round speaker. But in the meantime, just a word or two about attendance. We're going to be taking attendance at 8:10, looking at the participants list of the WebEx. If your name is listed clearly, you'll get full credit for attendance. If you're calling in or some other situation, you can email your attendance to me or Michelle or Beth. And with that, Dr. Ananth, are you ready to introduce our speaker?
Yes, I am. So good morning, everyone. I'm delighted to have Dr. Erica Gunderson today to present grand rounds in our department. By way of brief introduction, Dr. Gunderson finished her undergrad training at Stanford University, went to University of California at Berkeley to complete 2 masters in nutritional sciences and public health, stayed on in Berkeley to complete doctoral training in epidemiology. She is currently a full professor in the Department of Health System Science at Kaiser Permanente Bernard J. Tyson School of Medicine, and is also a senior research scientist in the Division of Research at Kaiser Permanente, Northern California. She is a reproductive life course epidemiologist who studies the impact of pregnancy and lactation on future metabolic and cardiovascular diseases in women. She also has very strong interest in studying fetal exposures and early postnatal dietary intake that affects childhood growth and health. Many of her studies are characterized as being one of the first to distinguish antecedent risk factors that precede adverse pregnancy outcomes and lactation as a major mitigator for cardiovascular diseases in women. Her research also focuses on studying early pregnancy blood pressure patterns to predict hypertensive disorders in pregnancy and to examine racial and ethnic disparities in maternal morbidity. Her resume is very impressive. I was browsing through her bio sketch, and she currently is listed as PI on at least 4 R01s that are in effect right away. And she's also a co-investigator on an R21. All of these grants relate to studying gestational diabetes, cardiovascular outcomes, as well as breastfeeding practices. She's no stranger to awards, the most recent of which is the Agnes Higgins Award in Maternal Fetal Nutrition from the March of Dimes, which she received in 2023. She has a very impressive publication record with over 150 papers. So I'm delighted to welcome Dr. Gunderson, who's going to be talking to us on lactation benefits women on cardiometabolic health, weighing the evidence and filling the gaps. So Dr. Gunderson, thank you very much for spending time with us for the next 45 minutes to an hour. We look forward to your interesting presentation.
Thank you so much, Dr. Ananth. I've really been an admirer of some of the work going on in the University of Rutgers department on birth cohorts. So I am so honored to be able to present some of the work that it has been quite challenging throughout my career, which, as you wonder, how does an epidemiologist start beginning to focus on pregnancy and lactation? And I had the very good training early on to work with OBGYN clinicians, and including maternal fetal medicine, OBGYNs, and nurse practitioner teams in public health. So caring for indigent pregnant women in community settings, and then preterm birth prevention with Cal Hobel. So this is really wonderful to be able to do this presentation. And I hope to share that, we know from about 40 years ago that lactation certainly has immediate cardiometabolic health benefits, and that's from Dr. Knopp's work on lipids quite a while ago in the 80s. But what's more challenging, and what I hope to review and help you to get inspired that we can generate more research, is what are the persistent impacts of lactation on women's future metabolic health and cardiovascular disease. So let me go ahead and make sure I'm advancing. I have no disclosures. I just have some NIH grants to acknowledge here. I'm coming to you early in the morning, of course, 3 hours earlier, and I live just north of the Golden Gate Bridge and have been lucky to do so for quite a while Kaiser Permanente, Oakland, their main office is across the bay further east. The objectives for the talk today to assess the evidence for lactation, as I said, and its future CVD outcomes in women with and without adverse pregnancy outcomes. And that factors largely in the discussion today and unanswered questions, and to identify two favorable effects during lactation that improve cardiometabolic health, describe study designs that minimize reverse causation in the lactation association with cardiometabolic health in women, state a key gap in lactation and CVD outcomes research, and finally, discuss postpartum care priorities and a care plan for women, including the timing of longer-term ASCVD prevention recommendations to encompass more of a precision medicine approach. And I just want to clarify that I'm using the term lactation because we really are studying the lactation that has a physiologic effect directly on the woman. Some studies use the term breastfeeding and future cardiovascular disease. That is technically breastfeeding a child. So either one is acceptable, but for my research, I tend to use lactation as the specific physiologic exposure. So what is the impact of pregnancy and lactation on future cardiovascular outcomes in women? We know CVD is the leading cause of mortality in U.S. women, and it accounts for nearly 1 in 5 deaths. Type 2 diabetes interferes with risk and peds risk of cardiovascular disease, and that's increased overall by 2 to 3-fold. But adverse pregnancy outcomes have also been identified fairly still recently, 2017, and increasing the risk by 20 to 40% in women, although as you'll see, there's probably much higher risk related to some of these significant disorders. For example, in cardio women with a history of gestational diabetes, one of the common adverse pregnancy outcomes that affects not only the woman's future risk of diabetes, but cardiovascular disease. Even women with GDM who don't develop type 2 diabetes have a 30% higher risk of CVD events than those that never had GDM. And in a study we undertook, we found there was a 2-fold higher risk of CAC, coronary artery calcium, 15 years later in women with gestational diabetes who, even if they maintained normal glucose tolerance, had pre-diabetes or developed type 2 diabetes compared to not having gestational diabetes. So there's an underlying mechanism that has to do with the adverse pregnancy outcomes themselves that increases risk. So this is the life course perspective of how reproductive risk enhancing factors might figure into future disease risk. And I think you're all acquainted with these in terms of, reproductive milestones and also certain diseases such as polycystic ovarian syndrome, infertility, of course, and then again, these adverse pregnancy outcomes that you're all very well acquainted with, the hypertensive disorders, GDM, preterm delivery and growth restriction. Parity has been looked at considerably in terms of its impact on cardiovascular disease with some mixed results. And then a risk enhancing factor or would be lack of breastfeeding potentially, although as we'll see later, some of the recommendations have not made any specific conclusions yet about this particular lifestyle behavior. And then of course, menopause and beyond. So the perinatal factors overview of what influences future cardiometabolic health are the following. We're very well aware of adverse pregnancy outcomes. There's been several studies on these hypertensive disorders and establishing there's an overall increased risk of cardiovascular disease. And those affect about 30% of all pregnancies. But preconception health has emerged as an important risk factor. And this has to do with the increasing rates of obesity, chronic disease, hypertension. And you can see the list there in women who enter pregnancy. And I'm sure you're well acquainted with managing some of these conditions. And that seems to affect at least 30% of all pregnant women. And finally, lactation has emerged as a potential benefit and risk mitigator. But the prevalence of lactation, according to recommendations, is fairly low. And the measures of lactation are just beginning to be explored in a quantitative manner. I'll just refer you to this AHA scientific statement from 2021 that deals with a very nice review of the relationship between adverse pregnancy outcomes and opportunities for CVD prevention. And it summarizes this variety of APOs that we just mentioned, but it also contains a section on lactation where I reviewed the current literature. So I'll let you read that for more details that I'll be as a resource after today's presentation. But normal pregnancy imposes cardiometabolic stress. It's significant, it's major. The blood lipids, particularly triglycerides and insulin resistance, accelerated starvation, which these very wide glycemic excursions upward and downward, and a fat mass gain, which can be anywhere from 2 to 6 kilograms on average. And that's depends on the particular individual, but it's both subcutaneous and visceral fat and inflammation. For cardiovascular demands are major, and the blood volume, the red cell mass does not increase a relative proportion. So there's physiologic anemia, heart has to work harder, and cardiac output is increased, and there's remodeling, and the size of the heart is increased, while arterial pressure decreases in the first 6 to 8 weeks and at least persists through 16 weeks, and there's decreased vascular resistance. Any of these physiologic changes in a short period of time in other individuals would be considered pathologic, but they're healthy demands of pregnancy, demonstrating the major adaptations that occur in women and that women must adapt to, and that those with potentially underlying chronic conditions or obesity may find difficult to adapt completely. And that's where the failure to adapt, either some underlying pre-existing condition or pregnancy in of itself stressing the adaptive capacity of the woman's vascular system and metabolic systems, results in these different APOs. And these are approximate estimates of their prevalence in the pregnant population. And what happens with these APOs? How are they linked to long-term cardiovascular risk? Because when we're studying lactation and its particular impact, we must take into account these conditions that place women at higher risk of cardiometabolic health conditions and disease. And as you can see, the hypertensive disorders of pregnancy are generally twofold to potentially fourfold higher when you get to cardiovascular disease, stroke, and heart failure, and gestational hypertension somewhat as well. But gestational diabetes is somewhat less impactful for CVD somewhat and heart failure, but still diabetes is the major 4 to 10-fold higher risk for women as a cardiometabolic outcome of GDM. And just to give you an illustration of the impact of parity versus GDM, because there have been many studies that have claimed that parity, grand multiparity, increases the risk of diabetes in potentially coronary heart disease in women. But most of those studies are from older cohorts that did not have any information on adverse pregnancy outcomes, APOs. But Cardia is one study that is prospective cohort of childbearing age women, those with and without births. And as you can see, once you account for whether the women ever had GDM, the incidence rate of type 2 diabetes is exorbitantly high. It's sixfold higher than it would be for women in the same age range in a 20-year follow-up who either had no births or only had one or more, any number of births. On average, it was about 2.3 for this more modern, younger cohort. Without GDM. So the rates were mainly due to gestational diabetes. And keep that in mind when you're thinking about risk factors. We also have looked at gestational diabetes and glucose tolerance after pregnancy, after a last birth, and future coronary artery calcium in women. And that's coronary artery calcium, or CAC, is strongly linked to future CVD outcomes. MI, heart failure, those major events. And we can study this more carefully in younger cohorts. And these are the data that I mentioned previously. Is the GDM group is in blue, the no GDM is in red. And it did not matter during this 15-year period after the last birth whether the GDM women had actually maintained normal glycemia. Their risk of developing CAC was twofold higher across these glucose intolerance groups. So lactation has also been looked at in terms of, well, what are the excess deaths in U.S. women that might be attributable to suboptimal breastfeeding? And 78% of those maternal deaths were due to myocardial infarction, breast cancer, and diabetes. So the conclusion of these authors, looking at the excess death rate that could be prevented by potentially improving breastfeeding, is that it has a larger impact on women's health than previously appreciated. And I think this is ongoing research, and the challenges of research that I'll illustrate in a minute make this point still relevant today and continuing. But these are the breastfeeding rates for any breastfeeding by 12 months, it's 36%, and exclusive breastfeeding at 6 months is about 25% in the US. These rates have not changed very much in the last few years. And you can see that these are well below what the recommendations might be. And what is the impact of lactation on glucose tolerance at 6 to 9 weeks postpartum after GDM? Let's look at the immediate effect of lactation, which I mentioned we have great information on longitudinally, and this is a cross-sectional view, but some have suggested that obese women really they just can't produce enough milk, so that anything to do with lactation is due to reverse causation. But in this cohort of well-described GDM who all underwent an OGTT for diabetes, you can see an inverse association between normal glycemia and going from high breastfeeding to much exclusive high formula feeding. And that's the blue bars are the normal glycemia, pre-diabetes in pink, and overt diabetes in red. And we also looked at the subgroup of women with obesity in the SWIFT cohort with GDM. And we found the same fairly consistent association that you had the exclusive breastfeeding and mostly breastfeeding with normal glycemia. Of course, some of this is the impact of lactation. So the longitudinal evaluation that that followed is critical, but the overall pattern is very similar in the obese women. Others suggest that, there are differences by, again, across BMI groups, and these are different by race, ethnicity, in the percent of non-initiation of breastfeeding. And you can see that within each of these BMI groups and across the racial ethnic variation in groups, it's fairly a similar pattern within each of the BMI groups, suggesting that it's not so much BMI, but potentially differences in cultural or other risk factors associated with BMI that might affect breastfeeding rates across these various subgroups. So the missing link and future CVD in women really has to do with lactation's impact on cardiometabolic risk factors. And what is the impact of lactation? How does it affect maternal cardiometabolic status and circulation? And so during lactation, these are the immediate effects. And you see that you reduce triglycerides more rapidly, you increase HDL levels, and a large amount of cholesterol is output into the milk, and that will alleviate the increased lipid load that pregnancy produced in women. And there's also lower glucose levels and reduced insulin demand, and this is because there's non-insulin mediated glucose uptake by the mammogram of about 50 grams per day. Increased energy utilization, and overall fat mass is reduced modestly, and some mobilization in different depots. And this is, again, just pictorially what happens with lipids. It's basically preconception. During pregnancy, you can see these major increases in especially the total cholesterol, but markedly in triglycerides, and those sort of subside thereafter. But what this diagram doesn't show is the differences by lipid, and that by lactation, and that's a limitation of most of the studies that are longitudinal in these obstetric populations that go through the postpartum period. Lactation subgroups are not considered in illustration of the changes, although a longitudinal study that I conducted in the Cardia study did look at pre-conception, in effect, pre-lactation, lipid levels, fasting lipid levels, and then looked at lipids again 1 year postpartum for changes in those specific lipoproteins and total cholesterol. And the only significant difference is the lower HDL cholesterol in women who breastfed or lactated less than 3 months compared to those who had breastfed 3 months or longer. And this was highly statistically significant and very confirmed earlier evidence in a much smaller study by Dr. James Roberts. So let's look at this mechanism of this non-insulin dependent glycemic control. There's a shift here with lactation. Lactation produces prolactin in the pituitary gland, and that is responsible for supporting lactogenesis and production of the milk, and also glucose, moving glucose from the liver and the other metabolism from the muscle and the adipose tissue, and so that there is a shift towards glucose uptake and utilization by the mammary gland, and that gets moved into the milk. So this is in effect potentially unloading the pancreatic beta cells because there is lower insulin demand to clear the glucose from the maternal circulation and the liver synthesis. What about weight changes during lactation, body composition changes? Surprisingly, there is very little longitudinal data. This is one of the few studies that uses the gold standard of DEXA or MRI changes in body composition, free fat mass, and BMI. You can see that in this particular longitudinal evaluation by 6 months postpartum, there's basically no differences in fat-free mass, very slight, non-significant. Even the difference in fat mass, which was about 1.5 kilos, fairly modest with exclusive lactation, was not significantly different. And the BMI was slightly different. So not enough to explain cardiometabolic benefits in particular, slightly, but fairly modest and non-significant differences, surprisingly. So what evidence is there that there actually may be some differences in cardiometabolic health that persist after lactation? And what types of biochemical evidence and epidemiologic evidence can we trust, and where are the strengths and weaknesses in those data? So one of the best studies to look at this research question is the CARDIA study, which is coronary artery risk development in young adults. It's a 35-year U.S. multi-center study, 86 to 2022, and that it's a 50% Black women and white women. They were 18 to 30 years of age, of almost 2,800 women at baseline. And there are 4 centers, and Oakland, Kaiser Permanente Oakland is one of the CARDIA centers. So I was lucky enough to work with these data and get longitudinal data that might help provide more robust biochemical data to support or not confirm lactation and other APO benefits. And the data we initially did in the 20-year follow-up was to look at incidence rates of the metabolic syndrome during 20 years follow-up with lactation duration, lifetime lactation duration. And as you can see, there was an inverse association for increasing duration of breastfeeding with lower risk of incident metabolic syndrome in both GDM births and non-GDM, again highlighting the importance of accounting for APOs. As you can see, at 9 months of breastfeeding, the incidence rates for GDM and non-GDM became the same, even though GDM itself is associated with much higher risk of the metabolic syndrome. We also looked at coronary artery atherosclerotic plaques present at 20 years follow-up and found that there was a borderline significant association in the adjusted model with longer duration of lactation and the lower percentage of plaques. And then finally, we wanted to look at what could we link lactation to much longer progression to type 2 diabetes, and did the 30-year CARDIA study, where CARDIA is designed in such a manner that exams happen with a full cardiometabolic testing, biochemical data, blood pressure, lipids, glucose, insulin, OGTTs, almost every 5 years. And women had pregnancies across these exam periods so that we could look before and after each pregnancy and time varying models of main effects, covariables, and outcomes. And the main outcome was incidence rates, time to event, a Cox proportional hazard model for incident diabetes. And lo and behold, lactation duration was associated with inversely with longer duration of lactation and lower risk of incident type 2 diabetes in the cohort. And it was found both in women with GDM, much lower incidence with longer breastfeeding, and those without gestational diabetes. And these are the actual models showing you an inverse association adjusted for race, time-dependent parity and GDM. And there's a dose response association with no lactation as the referent group, and then increasing lactation showing increasing almost about a 50% relative risk reduction. And this persisted even after control for time-dependent lifestyle behaviors, and it persisted with adjustment for a potential mediator, which was weight change during this 30-year follow-up period beyond pregnancy. This is the actual plot of those associations. Again, just to emphasize, there seeming to be some sort of a biologic plausibility. We also looked in the same cohort at lactation and duration and visceral and pericardial fat in women during midlife, where Cardia had done these scans of the heart and the liver and the abdomen. And what you can see is there certainly is an inverse association with lower visceral fat with lactation, as well as for the first time lower pericardial fat with longer lactation, suggesting that lactation might be mobilizing ectopic fat and reducing that in some of the organs. We also found the same finding for lower liver fat. So let's look at actually the data from large epidemiologic studies that look at lactation and the self-report of CVD risk factors in women. And these studies are prospective studies, but they are prospective often decades after childbearing has ended. They start in either midlife or late life. And you can see that these are very different than the data I just showed you, which are in women from the start or close to the middle of their childbearing years, depending on what age they began to bear children. But these studies are mostly in much older women who have no information on APOs or the risk factors that preceded lactation. So you can see there are modest reductions of 9 to 19% in ever versus never breastfeeding and cardiovascular risk factor reduction. One is hypertension reduction by 22%, and PROBIT, a cluster randomized study, found no difference in systolic blood pressure, although they didn't measure blood pressure any close to pregnancy, postpartum, or in the particular cohort. Swans looked at no breastfeeding and found higher risk of aortic calcification and CAC, almost threefold, with for no breastfeeding versus none versus having breastfed at least 3 months or more. And the Nurses' Health Study has found increased risk of CHD events with lower breastfeeding, but fairly long duration associated with this very modest 23% reduction, a 2-year duration. And then all-cause mortality has, in the same Nurses' Health Study, has been very modest, and again, not showing any sort of dose response type of relationship with mortality and breastfeeding lifetime. So again, a weakness of all of these studies are that there are no adverse pregnancy outcomes taken into account. Again, lactation and hypertension meta-analysis, similar findings of this modest 12% decrement in relative risk of hypertension, self-report of hypertension, but no benefit with increasing lifetime lactation over greater than 6 or 12 months. Older women, no graded association, no antecedent risk factors or APOs. Another study Very similar findings, slightly different outcomes, CVD hospitalization. CVD mortality, though, seemed to have a stronger risk reduction, but again, at very small, modest events at these longer intervals of lactation in this particular birth cohort, and no association for greater than 12 months per child. Another huge systematic review and meta-analysis of 1.2 million Paris women reported on lactation duration and maternal CVD risk. And again, same findings of modest association, 14%, 12% relative risk reduction of ever versus never breastfeeding, and the control for some reproductive risk factors and sociodemographics. But we didn't see any data about adverse pregnancy outcomes and how that might impact breastfeeding as well as the disease outcome. These studies are in older women, largely CVD events that are later. They're not in proximity to the early onset of CVD, can't be evaluated in these studies. And as you can see, there are, reproductive variables, the age of childbearing number or parity, but there's no APO data. That's a major limitation of this compilation of several studies that are listed here. They're major epidemiologic studies that never collected information on the pregnancy complications that we know are associated with these CVD outcomes. So I am referring you for more information about these limitations that I review in this article, The Missing Link in Discovering the Role of Lactation. And the missing link is that we don't have data on adverse pregnancy outcomes. In the vast majority of studies looking at the relationship between lactation and cardiovascular disease in women. And the reason this is problematic is because if you have pre-pregnancy health, you have a reasonable risk of having fewer APOs. As you can see that there's only one woman out of the many that developed an APO. But if you have elevated CVD risk factors before pregnancy, you have a much higher chance of developing one or more APOs, and that may cause a barrier because of complications related to that adverse outcome that pose inability or later onset of lactation. And those barriers aren't going to be as prevalent in women that have no APOs. So you may see the relationship that's a decrement or in risk due to the optimal CVD health of the women that went into pregnancy rather than lactation really being the link to the benefit. But we don't have APOs accounted for in most of these studies, so we don't know if there is reverse causation in protective association with cardiovascular disease risk reduction due to the fact that women with APOs may have more barriers to breastfeeding. Here's one study, prospective study, that actually looked at breastfeeding and controlled for APOs. And this is the Danish birth cohort. And you can see there was certainly an adjusted lower relative hazards of hypertension with increasing duration of any breastfeeding. And stratification by BMI revealed that normal BMI, you seem to have the same relationship, but perhaps with overweight and obese women, there might be a slightly different relationship, a decreasing risk at a threshold, and some sort of problem with duration of breastfeeding for those women that may be physiologic or due to other clinical risk factors or cultural. So let's identify the key research gaps. We have randomized clinical trials Their feasibility and validity is challenging. Individual randomization is not desirable or ethical. Cluster randomized trials have many limitations. They're expensive. And the current one that we have, which is the Belarus study, the PROBIT, also lacks data on APOs, and they actually never screen the women universally for gestational diabetes. So gestational diabetes occurrence is completely unknown. Low statistical power. If you have breastfeeding support study, which this randomized trial was, you don't have an unexposed group. All women are exposed to lactation, breastfeeding a child for an extended period. And again, we already discussed this, and I'll just mention it briefly here, is these studies in observational cohorts in older women in general, WHI, NHS, and the Million Women combination studies are susceptible to reverse causation due to unmeasured confounding. And in particular, it's not only the unknown APOs, but it's unknown preconception or early gestation cardiometabolic risk. We don't have good information on what were the risks entering pregnancy before lactation started that might explain lack of association or greater protective association. And these are lifetime risk of lactation and cardiovascular disease, but they don't measure intensity of lactation. None of the studies have done that in cardiovascular disease. So here's the diagram of what we mean by reverse causation. And if you have your preconception health could be a combination of chronic disease related to obesity or healthy obesity. And then lactation can occur, and you may develop, if you develop an APO, and you're more likely because of chronic disease, you would have a higher risk of diabetes, and you'd also have a higher risk of CVD, as well as the APOs. So your lactation might be reduced because of that. Again, if you're healthy, you are less likely to have an APO, but you might have C-section or high gestational weight gain that might impact your ability. But your lactation will have more favorable effects, potentially on lipids, blood pressure, insulin, and adiposity reduction, as we mentioned. But those with no APOs are likely to have lower risk of diabetes, hypertension, and stroke. And that means that the preceding initial disease risk caused the lower lactation rather than lactation causing the benefit to disease risk. And so we have to be enormously careful and aware of study design techniques to reduce reverse causation. And these are a couple examples of studies that are longitudinal that actually address the issue of not only adverse pregnancy outcomes, APOs, but actually what is the preceding, the antecedent risk, cardiometabolic risk before lactation and before pregnancy in the case of cardia. So SWIFT is my postpartum cohort of women with GDM followed from about 6 to 9 weeks postpartum and antecedent risk factors. And they recruited from these parts of Northern California. This is the overall study design, which spans from pregnancy, and then all of them were tested with OGTTs at 6 to 9 weeks postpartum, and then followed with OGTTs repeated. We're at a 10 to 12-year follow-up, and luckily we have electronic medical records. This is an illustration of our method to measure lactation intensity, and it's a score, and the three groups are divided by the score, and you can see it, they get discriminated pretty well based on very short intensity and duration of lactation, and then the black and then the green being the longest and almost the full score. It's a very diverse cohort of 75% minority women, only 24% white, and 25% low income. This is the inverse incidence rates that decrease with increasing lactation, formula on the left and exclusive lactation on the right. And these are the actual incident cases in the 2-year follow-up period, and the incident rates that you can see that subside and decrease by about half with the exclusive lactation at baseline. They're similar in OGTT at during pregnancy. That's our antecedent risk factor, and there was no difference in the treatment, which would be a severity indicator. But there was a slightly higher BMIs in the formula feeding group, but they also had more C-sections in that group. We had no difference in as I said, the C-section and labor were longer. We had slightly higher body fat with delayed lactogenesis, but there was no difference in the insulin resistance. So some of these delays could be due to the characteristics of the deliveries. But these are the same models that I showed you for cardia, where we have this strong inverse association. We're adjusting for all the perinatal and newborn outcomes. The lifestyle behaviors, it persists. And again, this weight change, which should be a mediator of diabetes risk, if that's the mechanism, did not ameliorate this strong inverse graded association with 50% relative risk reduction with higher baseline breast milk intake, exclusive breastfeeding. So let's look at the mechanisms, and I'm going to try to wrap up really quickly here and mention a couple other issues. But we have prolactin, oxytocin, the mammary gland. We have some lowering of suppression of adiponectin, and lower visceral and pericardial fat. There's minimal differences in weight loss, slightly higher with exclusive lactation, but not a major component, it seems, in these models of risk. We have really nice more rapid decreases in triglycerides, lower glucose and insulin, and an increase in HDL cholesterol, which is a major risk factor mitigating type 2 diabetes. So potentially prolactin is still supporting the pancreatic beta cell mass and function, but lowering the insulin secretion to spare, and having lower liver fat may also impact insulin resistance lowering. So one concept, since we're in the perinatal world, and PPCM is something that I've looked at, there's been some recent discussion about whether women with PPCM or heart failure during this window of pregnancy should be breastfeeding. And the etiology of this disorder is unknown, but as you can see, the PPCM develops within a window where these markers for preeclampsia surge, as well as where prolactin and oxytocin are differential with lactation, because both of those hormones support lactation. But this nice prospective study of PPCM cases that looked at changes in left ventricular ejection fraction found no difference across the breastfeeding and non-breastfeeding groups from entry 6 and 12 months. So the change in left ventricular ejection fraction did not seem to be affected by breastfeeding, was their conclusion, and the recovery was not impaired. So that is positive news for that situation. Although these prolactin is a mediator of potentially a PPCM, and potentially very severe cases would warrant potentially breastfeeding cessation. So our need is to fill the gaps, minimize reverse causation, collect data on history of APOs, and measure cardiometabolic risk factors. This is in an attempt for observational studies to approximate randomized clinical trials, so that if you can ensure equivalency of risk factors before lactation, that might help us be sure that we can minimize the direct influence of these preceding cardiometabolic health differences that might not only affect lactation and complications of pregnancy, but future cardiovascular and risk in diabetes. We've done that pretty well in Cardia and Swift with the GDM APO, but we need to do a lot more with looking at preeclampsia and severity of preeclampsia and other hypertensive disorders of pregnancy that certainly can affect both lactation, perinatal outcomes, as well as future cardiovascular disease risk. And we need to solve that. And it's difficult because of the long latency period of pregnancy and these epidemiologic cohorts that have self-report of some of these disorders are not ideal. We also need better methods to quantify lactation. So these adaptations or lactation happen in a very critical period, and it's a short window that lactation might be able to reverse the adverse cardiometabolic health effects of pregnancy and reset the cardiometabolic health more closely back to preconception levels. And so it's really balancing the risks and setting some priorities for women for ASCVD interventions. And how valuable is lactation for that and supporting individuals who are at higher risk. We recently had a statement from the AHA, and their plan is talking about women wishing to breastfeed, but reinforcing essential 8 lifestyle in this period, which seems reasonable, but we also might be sensitive to competing priorities and potentially need more evidence and rationale to score breastfeeding as potentially having clear benefits for CVD health. And this has to do with AHA's Essential 8. Let's include APOs as risk enhancers. That's clearly involved in these statements, but why not include lactation in the AHA circle of lifestyle, which is particularly relevant for postpartum, and breastfeeding as a lifestyle factor as a mitigator of cardiometabolic risks. I'll refer you to this report in 2020 that gave more details on the studies and the limitations. And thank you for listening. I appreciate your attention. And hope that I'll stop sharing now, and perhaps we can have some questions. Thank you so much.
Thank you, Dr. Gunderson. Thank you for that excellent lecture. Are there any questions? I see a question typed into the chat. Patients with overweight and obesity are also more likely to have excessive gestational weight gain and a higher risk of postpartum depression. Any thoughts on how postpartum depression scores might impact the initiation and duration of lactation?
Yes. That is one of the factors I think we need to discuss in terms of priorities for postpartum care. That's highly, highly linked with either in a bi-directional manner, I think, with depression and lactation. And it has not been very well studied. But in my view, one of the last slides I show, I think one of the priorities is sleep, treating and screening for postpartum depression, and supporting lactation where it's possible. Oxytocin is supposed to improve mood, so there is a potential for that to help. But again, it depends on the severity of postpartum depression, I think.
I see that Dr.
Go right ahead.
I see that Dr. Patrick has her hand up.
Thank you. Good morning. I'm Haley Sweat Patrick. I'm one of the maternal fetal medicine attendings here. I'm also the person tasked with improving our breastfeeding rates here at the hospital, which are not at goal right now. And I have a lot of both personal and academic interest in everything that you were speaking about. I love, as an MFM and an obstetrician, when we talk about maternal benefits of breastfeeding, even though we know that there are also many benefits to the breastfeeding infant as well. I have two questions, if that's allowed, that I was thinking about as you were talking. One is, when I try to promote breastfeeding and get people excited about breastfeeding, a lot of the pushback I hear is that, breastfeeding is hard, and in this country, there are not a lot of protections for leave and breastfeeding moms. And we know that people who are successful at breastfeeding tend to be, higher socioeconomic status, tend to have more support at home, tend to have longer leave time. So I'm curious if you can touch on that and the impact those other factors may have on some of these outcomes. And then my other question is, has anyone looked at subsequent pregnancies? So, if you had GDM and then you breastfed or lactated, in your next pregnancy, are you more or less likely to have some of these APOs, GDM, gestational hypertension, preeclampsia, et cetera? I'd be curious to know if there's any data on that. And thank you again for your presentation.
Thank you so much for those questions. Excellent points. We demand too much from women. They're recovering from pregnancy. You saw those physiologic demands, and lactation is a way to recover if they choose to, or if they choose not to lactate. We have to be aware of that. But I think we don't even have lactation in the conversation in these current reports from the AHA on cardiovascular disease prevention. In a recent one on peripartum outcomes, it wasn't mentioned, but in the Louis article that just came out about 3 weeks ago, it's mentioned, but it's not mentioned as a major intervention for cardiovascular prevention. Maybe they're waiting for more data, or maybe it's the PPCM heart failure. But I think you're right. Our social policy is not aligned with the recommendations. It is extremely hard for working women and lower SES women to breastfeed per the recommendations, and also recover from a complication. And those may be the women that may benefit a lot from breastfeeding. The second question, yes, there's 1 or 2 studies out looking at lactation and GDM recurrence. I've done an analysis, but we haven't published it. It's very difficult to do a very tight, rigorous study, because the women with a history of GDM are going to be screened much earlier, and that sometimes they don't undergo the rigorous OGTT, and they're doing more home monitoring. So we found it challenging, but that's a great question. Yes.
I see Dr. Nant has his hand up.
Dr. Gunderson, thank you very much for this riveting talk. Offline, a few of my colleagues were texting back and forth saying what an impressive talk this was. So congratulations. Very nicely presented.
Thank you so much.
As an epidemiologist, I'm also delighted to see how good epidemiologic studies can begin to pave ways to understand the mitigating factors of breastfeeding and cardiovascular health. My question is very specific to really understanding your thoughts on how these risks for heart health versus stroke are different when women breastfeed. Any evidence to see the separation? And I'll add, the reason why I raised this question is because many of the studies that we have recently done, and the ones that are currently underway in our department on cardiovascular health, we are beginning to see that stroke risks kind of stand out for most of the adverse pregnancy outcomes, and less so for heart health.
I think that's interesting, a very interesting comment, particularly in looking at, the recovery of PPCM function, the heart function, that seems the comment about preeclampsia patients having better recovery than those without preeclampsia for PPCM in one article I read. But I think stroke has to do with blood pressure, correct? And if oxytocin is beneficial part of breastfeeding to relax the vasculature or lower blood pressure, that might serve as an important benefit. But I think you're right that there's going to be differential mechanisms, and we really know very little about the mechanisms for lactation's benefits. We haven't studied that is a completely open area of research. Just getting the epidemiology done well, I think, is the first step. But there is this pop hat trial. I'm sure you're well acquainted with it. It
Yeah.
was presented at AHA, and I talked to the investigator right after his presentation at AHA in November, and I said, "What do you have? How do you measure breastfeeding?" Well, they were breastfeeding. It's kind of a yes, no, but we only asked it early on, and they don't have any longitudinal data on breastfeeding change and blood pressure control. And these are patients with chronic hypertension that post-pregnancy. It's crucial to measure lactation quantitatively in these sorts of trials, that they're planning a much larger trial. And in studies of women with preeclampsia and progression to lactation, we need to do these quantitative methods like we did in SWIFT, and it just doesn't exist. And this yes no question in most of these epidemiologic studies, even the new mom to be heart health study, it's a yes, it's more of a yes no, and it's asked very late. So I think those studies aren't precise enough, is what I would say, and we need better methods about measuring lactation prospectively and methodically.
Yeah. Thank
The
you.
exposure's not well characterized is the problem.
Thank you.
Thank you so much. Great question.
All right. Well, Dr. Gunderson, thank you very much for joining us this morning.
You're welcome. It was my pleasure to talk with you all. Thank you so much for your enthusiasm.
Thank you.
Thank
So
you.
we're just about out of time, so we're going to end it here. I wish everyone a safe and productive day. Thank you.